now, completely spoiled.
So this is a 50-somewhat-year-old gentleman with HIV on ART, CKD. First it said proteinuria, but then it said hematuria. So
This sounds like business
Diabetes
speak.
and-
HIV on ART, CKD, tampon.
I didn't do anything with that.
He has enough problems.
I kept moving.
Yeah.
It is dense right there, but I let it go.
Well, so far
Don't
we've
see
got
anything so far.
a lot of
So looking
arterial
for, yeah, he's on
sclerosis.
dasatinib, I think. He is on tenofovir boosting as well, so I didn't see any what looked like. Yeah, there's tons of global sclerosis, not that bad IFTA, you know, it's maybe 20-25%, but I had a lot
Boy,
of
the vessels
global.
look horrible.
So we look at the globs, there's not too much.
No.
Well, that's FSGS. I mean, you
Yeah.
can't avoid it, but it's not a collapsing look.
No, so it's really kind of banal looking.
Yeah, it is.
Sort of the lymphoma there.
Except for that lymphoma that she went
Yeah,
on.
just keep going.
No. All right, so far, do we
So
need
look,
any
I
more
have-
on this?
Yeah, I have-
Yeah, because we've seen what we see here.
No,
Let's
the
look at
gums
the
are pretty
pictures.
nice, yeah. They were expecting high Vic because of the hematuria.
Yes.
Oh.
I don't know, it just said,
And high Vic instead of high Van for Autumn's.
I don't know if those are protein drugs.
Immune complex kidney disease, HIV.
One
So it's
association.
So-
it's usually lupus-like
Just one second.
pattern, so.
So talk about the two things that you might see and what we used to see and what we see now, high Vic and high Van.
Right, so HIVIN is typically what we associate with collapsing glomerulopathy in the setting of HIV, typically African Americans, and they usually have two one risk alleles. High Vic HIV associated immune complex kidney disease is typically lupus-like, and I was explaining to her, because it's usually, in our experience as well, full house.
Right.
It can look just like a full-bore lupus with hyaline, pseudothrombi, and wire loops, and, so I bring this case because it's IgA only.
Yeah, but high.
And it's IgA nephropathy.
That's actually one of the first HIV-GNs described by
You're right.
Kimmel
Mhm.
from, I know him, from Washington DC. And a lot of people initially didn't believe it, but you can see, not uncommonly, for some reason, IgA only.
Mhm.
Randy?
But there is somewhat of a controversy of what high Vic is.
Yes.
Some people would even clump this into the high Vic, which I think is totally wrong.
Well,
Other
you're right.
processes that are more lupus-like, yeah.
Right.
I mean,
That's why I brought this case.
and then
to
there are,
talk
so
about it.
sometimes you'll get a vague immune complex mediated process that's just difficult to
It's
classify.
an umbrella term.
It's an umbrella term, but my feeling is if you can identify like a membranous or IgA nephropathy or membranoproliferative GN in a patient with HIV, I mean, it is what it is.
Right,
It's-
and I did a little bit, and I always,
Yeah.
Shri always, that's why I showed this to Shri, because he always talks about this, like, this is
Right.
IgA until proven
Yeah,
otherwise.
yeah, exactly.
Right, and that's what I didn't talk to the doc, but I emphasized that in my comment, as opposed to lumping it into high Vic. And in some of the literature, when I searched, they actually compare these patients to IgA nephropathy, so they do
Right.
separate them out in studies. It's the only reason why I brought it, it's a
Yeah.
paper.
What was
I mean,
your
otherwise, there's nothing else, there's very little C3, and it's lambda more than kappa, so in any other case, if it wasn't
Yeah.
HIV, you'd say, oh, this is IgA nephropathy.
Exactly.
What
But
was your top line?
IgA nephropathy is comment.
So can I ask you a question?
And I mentioned high Vic Fred, but I say that the differential is primary and secondary causes, and then if those are excluded, then it could be, I guess, high Vic, though it's not classic, what's classically described.
Bobby has a question.
So when do you top line that as high Vic? I've never, not.
So this was the point that was
frequently
being
used.
discussed.
Yeah.
Shri?
Yeah, let's see.
Yeah.
When would you top
So
line?
if you give me this complete history that I have ruled out primary and secondary IgA patient is not having cirrhosis, then you can put it in the high Vic category, but not right now.
Yeah, because this is IgA.
Yeah, this is IgA nephropathy, so in HIV, I will rule out definitely bacterial infection, right? And this one, less likely because C3 is low, so it is combined. You have to give me whether there's a hep C or not, cirrhosis is present or not, so I will rule out. And she mentioned there are a lot of glands which are sclerotic in the background, so I have to see when was the HIV diagnosed, in which time frame, was the patient having hematuria
Right.
before this one or not? So it might be a primary IgA nephropathy
Yeah.
to start
This
with,
is
and
with
then
so
he
many
developed
global
HIV.
sclerosis,
Mhm.
yeah.
So as a clinician, I have to do some digging to make the diagnosis.
So Randy, then Nydia?
I would never top line anything high Vic.
Yeah.
I would always describe the pattern in the top line, and then
Even the lupus
crafting a
like?
comment to decide
Mhm.
whether or not I
Yeah.
think this is related to the
Yeah, that's,
HIV.
that was my question, like,
I top line
I've
it when I
never
have
Right.
seen the
IgA.
top line as HIVEC, I'm just saying.
I would never
immune
top it.
Let's go to Nydia and then we'll come back to Christie.
Yes, completely agree with Brandy, and I think that what Sri is mentioning is that in an IgA nephropathy, how are you gonna rule out as a primary? You
Yeah, you
won't.
can,
So you're gonna call IgA nephropathy, or you're gonna decide if you're gonna go to the numbers that gonna call any immune complex deposition as an as a
HIVEC.
if the patient has HIV, which is a school that I disagree, because I don't think HIV is a vaccination against the other genes.
Good point.
Basically, someone can have IgA, they can have members, and
They
they
can
can have
have
HIV. So, I think that in categories that are well defined, I don't think I would even put the comment, I would just call this
Mhm.
IgA nephropathy,
Right.
and that's
And I
it.
think viral load is important too.
Let's go to Christie.
Oh, I was just saying, I think, I agree, HIVIC can be overused, but when I really think it is HIVIC, like if I have HIVAN and a lupus-like, I will top line it HIVIC in rare cases, when it's applicable. But,
Brett?
and I usually don't say rule out primary IgA, because how are they gonna do that, maybe?
Right, how you gonna prove it?
There's no-
Fred has a point.
I hate to disagree with everybody, but I wouldn't even call it IgA nephropathy, because that's a specific diagnosis in a clinician's mind. I would call it something like mesangial deposition of IgA-C comment. I don't think there's a way we can tell whether it's HIV or whether there's primary IgA. Now, if the patient before more than 3 months had hematuria for a long time, then that might be a clue. But again, Kimmel has written lots of papers on IgA and HIV, so I don't think we can tell.
But Fred, based on this logic of yours, then I cannot ever call IgA nephropathy in any patient's period.